Comprehensive, relevant, and insightful conversations about health and medicine happen here on MedStar Health DocTalk. Real conversations with physician experts from around the largest healthcare system in the Maryland, D.C. region. At MedStar Health, we have experts specializing in each type of blood cancer, including the subtypes of the various diseases. Because our specialists focus exclusively on certain blood cancer groups, we have extensive experience in diagnosing and treating all cases, including those that are rare. The Division of Hematology and Oncology at MedStar Georgetown University Hospital is dedicated to the medical treatment and care of adults with cancer. Georgetown Lombardi Comprehensive Cancer Center, the region's only comprehensive cancer center designated by the National Cancer Institute, serves as our research engine, allowing patients access to clinical trials and breakthrough treatments and therapies in their cancer care. Welcome to MedStar Health DocTalk. I'm Ryan Miller, and I'll be your host for today's episode. Today we're focusing on lymphoma, hematology, and medical oncology. We are here with Dr. Kieron Dunleavy. Dr. Dunleavy is an internationally recognized lymphoma expert. He is a medical oncologist and hematologist who serves as Section Chief, Hematology, and Disease Group Lead, Malignant Hematology, for MedStar Georgetown University Hospital at the Georgetown Lombardi Comprehensive Cancer Center. Thank you for joining us on MedStar Health DocTalk.
Thanks very much, Ryan, for inviting me, and I'm very glad to be here on DocTalk.
Terrific. We're grateful for your time. So, what does the Malignant Hematology and Oncology program at MedStar Georgetown University Hospital have to offer?
As the Director of Hematological Malignancies at MedStar Georgetown, I oversee the team responsible for treating blood cancers, and that includes leukemia, lymphoma, and multiple myeloma, and some other cancers as well. Our physician teams work very collaboratively, engaging with each other, discussing promising treatments being developed in their specialties, sharing outcomes, and then partnering on some very exciting research projects within the group. And, really working within a multidisciplinary approach allows us to treat the entire patient and provide very comprehensive cancer care for our patients with blood cancers. And at MedStar Georgetown, our mission really focuses on the Jesuit tradition of cura personalis. We really care for the whole person. And we have many physicians and allied healthcare professionals who focused on different aspects of patients' health to ensure that we carry out our mission.
Terrific. Thanks for laying all that out there, and I look forward to hitting on some of the clinical trials and the multidisciplinary approach that you all have later on in our conversation. What kind of patients do you see on a day-to-day basis?
Yeah, so the patients I see all have a diagnosis of a lymphoid malignancy, and that really encompasses a huge spectrum of diseases, from aggressive diseases to indolent diseases. For example, the most common aggressive disease that we see is a disease called diffuse large B-cell lymphoma. There are, on the other end of the spectrum, indolent diseases like follicular lymphoma, chronic lymphocytic leukemia. We also see virally driven lymphomas, and we really see a lot of other lymphoid diseases that fit somewhere along the spectrum between aggressive and indolent processes. And a big part of our work, as well as delivering optimal care to patients with blood cancers, is engaging in clinical research and running clinical trials. And we have a number of clinical trials in lymphoma and in other blood cancers that are in different phases, phase 1, phase 2, phase 3. And these are a very important part of our efforts here.
Thanks for explaining that. Now, you've been a doctor a long time. Through all your years, what would you say your philosophy of care has been and is?
Yeah, so, I think the most important part of what we do is ensuring that our patients receive the best care and that they are able to take advantage of recent advances in the field where we have a lot of new treatments and new ways of approaching blood cancers. In the field of lymphoma, there really has been significant changes and developments over recent years, and the way that we treat our patients nowadays compared to 15 or 20 years ago is very, very different. There's been an advent of a number of really exciting therapies such as CAR T cells, bispecific antibodies. We have a lot of specific pathway inhibitors that are very effective in different types of lymphomas and leukemias and multiple myeloma. And we are frequently using many of these in the clinic, and they are associated in specific types of these diseases with better outcomes, and they have a very different side effect profile as well compared to conventional chemotherapy agents. And this is very welcomed for many of these diseases, where in the past, treatment was associated with a lot of toxicity. So we're really making efforts to maintain very high effectiveness and maintain high cure rates, but at the same time reduce toxicity, particularly in older people and in patients who are more susceptible to the side effects of some of these agents.
That's a terrific approach that you all have there, and we're lucky to have you at the helm of this program. For those who really have close to no understanding of it, like myself, what would you say, general explanation, what is lymphoma?
Yeah, so lymphoma is a cancer or malignant disorder of lymphatic tissue. We have lymphatic tissue all over our body. We have lymph nodes. Lymphomas may arise in lymph nodes, but even outside of lymph nodes, there really is lymphatic tissue everywhere. And a lymphoma can occur in really any organ in the body. Lymphomas are divided into T-cell lymphomas and B-cell lymphomas. They come from either a B-cell or a T-cell in the vast majority of cases. About 85% of lymphomas that we see are B-cell lymphomas, and about 15% are T-cell lymphomas. Interestingly, this differs if you look at various parts of the world. For example, in Asia, there is a much higher proportion of T-cell lymphomas. So this can vary quite a bit. Lymphomas vary from being highly aggressive to being very indolent or slow-growing. There are well over 100 different types of lymphomas, and they can be on various parts of this spectrum of aggressive versus indolent. And the aggressive lymphomas, while they can be challenging to treat at the very beginning because patients can present with a lot of symptoms and can be very ill, they are, for the most part, highly curable diseases. The indolent lymphomas are different in that they typically do not present in the same way as aggressive lymphomas, in that patients are typically not very unwell and they oftentimes don't have systemic symptoms. And these lymphomas are generally managed differently. A lot of patients with indolent lymphomas and chronic lymphocytic leukemia will not require therapy when they're newly diagnosed with the disease. And this is really because we don't know that instituting therapy for a lot of patients with indolent diseases is helpful. And what we do is we pursue what we call a watch and wait approach, where we watch and hope that things are not going to change very quickly and bring patients back every number of months to examine them, perform scans sometimes, do lab tests. And with indolent diseases, you can often see that people will not have significant progression of their disease for years or sometimes for decades.
Thank you for that breakdown. Just to piggyback off something you said regarding B cells and T cells, which one is more aggressive or worse to have than the other?
In answer to your question, the T-cell lymphomas are more aggressive overall. There are a fewer percentage of indolent lymphomas under the T-cell umbrella. But in B-cell lymphomas, the majority of them are aggressive. The most common type is diffuse large B-cell lymphoma, but a very high proportion of them are indolent. And the most common type of indolent lymphoma is follicular lymphoma.
Thanks for that, doctor. And the sooner you can catch something, the better, right? That applies to just about everything. So what are some of the signs and symptoms of lymphoma? What should people be on the lookout for?
Yeah, so there really are very many different signs and symptoms of lymphoma. Lymphoma can arise in a lymph node or can arise in an organ in the body. So depending on where the lymphoma arises, the symptoms can be very, very different. A very high proportion of people will present with an enlargement of a lymph node. The areas in our body where we notice lymph nodes easily are in the neck, under the arm, which is called the axillary area, and in the groin, which is called the inguinal area. So a high proportion of people will notice a lymph node swelling in one of those areas. What happens is that they will typically go to their primary doctor after a few weeks. If the swelling persists, they will often get a course of antibiotics, and if the swelling is not better, after that they're referred to a surgeon and the diagnosis of lymphoma is made. But there are a lot of other ways that people can present with lymphoma. There are symptoms that are called B symptoms. We always ask our patients about these because they are symptoms that can indicate the presence of lymphoma. And these symptoms are fevers, night sweats, and weight loss of more than 10%. So we always ask people about those symptoms. Now, most people who have a new diagnosis or presentation of lymphoma will not have B symptoms, but some people will. And B symptoms are associated with some specific types of lymphoma, and they're sometimes associated with more aggressive presentations.
I've read about young people getting Hodgkin's lymphoma. Just the other day in the news, a National Women's Soccer League player for the Orlando Pride, only 30 years old, and she has Hodgkin's lymphoma. Is there a reason that younger people are susceptible to it? Are older people also just as susceptible to it?
Yeah, that's a very good question. Younger people are definitely more susceptible to it. The majority of cases of Hodgkin lymphoma occur in adolescents and young adults and are more common in females than males. We don't completely understand the reasoning for that. There are a minority of these cases that are associated with a virus, EBV, but most of them are not. With Hodgkin lymphoma specifically, we see something called a bimodal distribution where there's a peak in people in their adolescence and 20s, and then there's another peak for people in their 70s. That they're both called Hodgkin lymphoma, but if you dig a bit deeper, it actually turns out that for younger people, the majority of them have a type of Hodgkin lymphoma called nodular sclerosing Hodgkin lymphoma, whereas older people, a very high proportion of them have a type of Hodgkin lymphoma called mixed cellularity Hodgkin lymphoma, and that is frequently associated with the EBV virus.
I was unaware that there were multiple types of Hodgkin's lymphoma. Interesting. How is lymphoma diagnosed and how is it treated? When do you come in the process of a patient's journey?
So when a patient sees a lymphoma specialist, the diagnosis of lymphoma has typically been made at that point because that's why they're referred to a lymphoma specialist. People will present with the symptoms that we talked about. They may have lymph node enlargement or other symptoms depending on where the lymphoma is. And they will ultimately undergo a biopsy, whether that's a biopsy of a lymph node or a biopsy of an organ, and that will yield the diagnosis of lymphoma. When we diagnose lymphoma, the biopsy is obviously hugely important, and it's really critical that the pathologist who makes the diagnosis of lymphoma has adequate tissue to make the diagnosis. So for a lot of lymphomas, you can make a diagnosis with a core biopsy diagnosis, which is getting a small amount of tissue from a lymph node or an organ. But it is recommended in a lot of cases that you get what's called an excisional lymph node biopsy, where the entire lymph node is taken out. And the reason for that is to give adequate tissue to the pathologist to make sure that they are 100% comfortable in diagnosing the lymphoma. There are hundreds of different types of lymphomas, and many of them can appear very similarly. And it's really critical to know which type of lymphoma you're dealing with before you start treatment, because the treatments can be very different. So when we're in the clinic and we have a new patient with lymphoma, we really focus on how the diagnosis was made and if there's adequate tissue and if our pathologists are 100% comfortable with the diagnosis. And if they're not, then we sometimes need to obtain more tissue or perform another biopsy. But that is one of the most important discussion points when we see a new patient in the clinic, just making sure that we have the correct diagnosis, because, as I said, it has implications for the type of treatment that someone receives.
If you need to obtain more tissue, is surgery required to remove a lymph node? How do you go about doing that?
Yeah, so sometimes we don't need to do surgery. We can do a biopsy in the radiology department. So we have an interventional radiology department where they can use imaging to guide them to do a needle biopsy in a particular part of the body. But if that's not an option, or if more tissue is required, then general surgery is required, where a patient has to have an excisional lymph node biopsy and the entire lymph node removed.
What's the recovery look like with that?
The recovery is very fast with lymph node biopsies. So it's already a day or two. It's not considered to be major surgery. It's very minor surgery.
Yeah, it's good to know. So you serve on the scientific advisory board of the Lymphoma Research Foundation and on the editorial board of several journals. You've also published more than 100 manuscripts and textbook chapters and frequently present your research across the country and the world. Can you tell us about some of the lymphoma and multiple myeloma research you are involved in, or some memorable ones that you have been in the past?
Yeah, sure. So I'm interested in a broad range of lymphoma research. I'm particularly interested in the lymphomas that younger people develop. So I've done a lot of work in lymphomas like primary mediastinal B-cell lymphoma and Burkitt lymphoma, and have done work with the pediatric groups in developing treatments for these patients. Currently, we're working on a national study using a type of drug called an immune checkpoint inhibitor in patients with a new diagnosis of primary mediastinal B-cell lymphoma. And that's a study that is being run by the National Cancer Institute cooperative groups. And it's important because it is being run in both the pediatric groups and the adult groups. So that's one study that I'm working on currently. And we have that study open at Georgetown. And we're working on a number of other exciting lymphoma studies at MedStar Georgetown. We have a study that is looking at the role of virus-specific T cells. My colleague, Dr. Rozwarski, who's a lymphoma specialist, is running a study using a drug called mosunetuzumab, which is a bispecific antibody in patients with a new diagnosis of follicular lymphoma. And we have a number of other studies throughout the spectrum of lymphoma, indolent, aggressive, and chronic lymphocytic leukemia that we are running currently.
That's wonderful that there's so many different trials that you all are involved with. So for the clinical trials you were referring to, if someone is interested in participating, how would they go about doing that?
Just contact us. They would call the main number here, which is 202-444-2223, and explain that they were interested in enrolling on a clinical trial, and it would be organized from there in terms of how they would be able to come in and set up an appointment, etc.
That's great. I mean, on top of all the patients you see, you all are still on the cutting edge of clinical breakthroughs, and it's really impressive that you guys can fit that much on your plates. Dr. Dunleavy, what's the difference between Hodgkin lymphoma and non-Hodgkin lymphoma?
Yeah, so the the majority of lymphomas are non-Hodgkin lymphomas because Hodgkin lymphoma is a particular type of lymphoma that has a distinct type of presentation, typically affects young people. There is what's called a bimodal age distribution where older people can also get Hodgkin lymphoma, and how it looks under the microscope is very distinct from non-Hodgkin lymphomas. So the lymphomas are divided up into a minority Hodgkin and the vast majority non-Hodgkin.
Dr. Dunleavy, can you prevent non-Hodgkin lymphoma?
So the majority of people who develop non-Hodgkin lymphoma have got no known reason why they develop it. So it is not preventable in the majority of cases from what we understand currently. There are people who have a disease or a condition that makes them more likely to develop lymphoma than people who do not have that. There are certain infections. There are people who are on certain medications. Rarely people who are born with certain genetic disorders that are associated with a higher risk of developing lymphoma. Also, there is a higher risk of developing lymphoma in patients who have received solid organ transplants. So if patients have received kidney transplants, for example, they have a higher risk of developing lymphoma. But the vast majority of people who develop lymphoma have got no known risk factors, and we don't understand why they develop lymphoma.
That's fascinating. And are there any lifestyle habits that someone can have that could potentially help lower their risk for developing various cancers?
So, there are for other types of cancers, but I'll speak about lymphoma, and we're not aware of any lifestyle causes for the development of lymphoma. Of course, that's very different to the gastrointestinal cancers, for example, and lung cancer, which is associated with smoking. But for lymphomas, no, we are not aware of lifestyle behaviors that are associated with an increased risk of developing lymphoma.
Thank you for that explanation. Why is an accurate diagnosis critical to someone's treatment?
So an accurate diagnosis is critical because there are so many types of lymphoma. There are over 100 different types of lymphomas recognized, and it's critical to identify which of these types a person has because they are treated differently depending on what type of lymphoma it is. So getting the diagnosis right, and it's the pathologist who makes a diagnosis of lymphoma based on a tissue biopsy. Getting that diagnosis right is really critical because it can inform on the next steps and can inform on the type of treatment that is used. So it's really important to know 100% which type of lymphoma you're dealing with.
Well said. When it comes to survival rates for lymphoma, what do those look like?
Yes, so the good news is that lymphoma is a very curable condition, and for a high proportion of cases that are not cured and that are indolent, people can live for a very long period of time. They can live for decades with indolent lymphomas, and it's very possible nowadays that when someone has a diagnosis of an indolent lymphoma, that it is not going to shorten their life expectancy. But a high proportion of these are curable. The most common type of lymphoma is diffuse large B-cell lymphoma, and really approximately 80% of patients can be cured with this lymphoma. If you look at patients, particularly with early stage diffuse large B-cell lymphoma, they have a very, very high cure rate with standard approaches. And as people have higher stages of disease, the cure rate drops. But the good news is that we're continuing to augment the curability of this type of lymphoma, and new treatments are being developed all the time with a goal of doing this.
That is so encouraging to hear. It sounds like you can beat this and then still live a vigorous, healthy lifestyle.
Yeah, exactly. And it's a bit different in terms of the aggressive lymphomas and the indolent lymphomas because the aggressive lymphomas are highly curable. So when patients complete therapy, they really return to having a normal life, just like they had before they had the diagnosis of lymphoma, and they undergo what we call surveillance, where they have to come back to the clinic every few months for probably imaging and a physical exam and labs. For those patients with indolent lymphoma, it can be different, where the lymphoma will continue to be there, almost like a chronic disease, and will require treatment if it starts to cause problems or issues. But for the most part, those patients come back to the clinic every few months for surveillance and have very, very good survival rates with current approaches that we have.
That's great to hear that it can be so manageable. What are questions that someone should ask their healthcare provider? What's something that patients don't ask you enough that you wish they would?
So one of the most important questions for people with a diagnosis of lymphoma, whether they are newly diagnosed with the disease or the disease has come back after prior treatment, is, do we have the diagnosis right? And that really boils down to the pathologic diagnosis. So I think that is one of the most important questions a patient who comes to our clinic can ask, because the diagnosis is necessary for deciding on therapy. So it is really critical that the diagnosis is correct. So I think that is a very important question for patients to ask. Other questions are if there are choices of treatment, if there are different types of treatment, to learn about these different treatments, to learn about the outcomes in terms of cure rates, learn about toxicity, and also ask about clinical trials, because we have a lot of exciting clinical trials for people with lymphomas and CLL, and it's really important to know about them, because sometimes there can be a clinical trial that is going to make a huge difference and is going to become standard treatment once the trial results read out. So being part of clinical trials is really important for a high proportion of patients.
All great points. So listeners, please keep that in mind when you're talking to your doctor. Dr. Dunleavy, tell us about the expertise for diagnosing and treating other blood cancers through the program. Why should a patient choose MedStar Georgetown?
Yeah, so within the hematologic malignancy program, I've talked a lot about lymphoma, but we have fantastic experts who are focused on other blood cancers, such as leukemia and multiple myeloma. So at MedStar Georgetown, we have a myeloma program and a leukemia program, and both of those are focused on absolutely novel molecular diagnostics. We have a lot of great clinical trials that are running in leukemia and multiple myeloma, and a good multidisciplinary group of people. So this is an excellent institution for other blood cancers as well as lymphoma.
Sounds like we've got you covered no matter the blood cancer. Dr. Dunleavy, you've touched on some of the advancements in clinical trials that are underway. What does the future of lymphoma, hematology, and medical oncology care look like? Is there reason for optimism?
Yes, I think there's reason for huge optimism. We continue to augment cure rates for patients with lymphoma and blood cancers and also other types of cancers. That obviously is the most important thing, that we're able to eradicate these diseases. And in doing that, we are also starting to develop a lot less toxic treatments for patients. So in the past, people received very high doses of chemotherapy for a lot of diseases. And now the treatment landscape is really being transformed with a lot of novel approaches that don't have the same toxicities as these treatments from the past. And that's really important for patients. So we want to maintain high cure rates, but with less toxicity. And there's a lot of research and focus in that area at the moment. We're getting much better all the time at understanding cancers and understanding specific pathways and what drives them. And importantly, what can be targeted and what can be interrupted to stop cancers and to eradicate them. And that hopefully translates into curing a patient. One big breakthrough that is ongoing is being able to detect cancer cells in the blood. So we are now able to perform something called a liquid biopsy in a lot of different cancers. And we're able to get a huge amount of information from that liquid biopsy, which can be very helpful at various stages of a patient's journey. We're really just at the tip of the iceberg with liquid biopsy and other similar types of technologies which are currently in development. But these and other approaches and new treatments, I think, really mean that the future of cancer care is very optimistic. And as I said, most importantly, we continue to augment cure rates for patients with cancer and at the same time reduce treatment-related toxicity for them.
Wow, definitely sounds like the future is bright. I have learned so much from my conversation with you and really grateful for all the time that you've given me today. I've been talking with Dr. Kieron Dunleavy at MedStar Georgetown University Hospital in Washington, D.C. Thank you for sharing your expertise with us today on MedStar Health DocTalk.
Thanks very much, Ryan, for the opportunity to be here. I very much enjoyed it.
For more information or to schedule an appointment, call 202-444-2223.